So good afternoon. On behalf of Delhi Gynecologist Forum and the Quality Improvement Committee of AOGD, Dr. Aparna and myself extend an extremely warm welcome and deep gratitude to all my respected seniors, colleagues, and friends, all who have logged in today for this very, very significant and important webinar. We as obstetricians have a moral and an ethical duty to ensure that not a single baby is born with thalassemia major, because this is one disease that can be diagnosed and detected very early in the pregnancy. The aim of this webinar today is to create awareness about the fact that we have so many modalities to be able to detect this particular disease very early in the prenatal period. And if we do have women who are thalassemic minor or major, and they do conceive, how we can optimize the pregnancy outcomes in this women. This webinar today is actually a culmination of a deep desire and the efforts of Dr. Sharda Jain, one who has really fought to make India anemia-free. And thus, I invite Dr. Jain, the Secretary General of DGF, a mentor with the mission and passion, determination and action to truly set the right context for the webinar today. Madam, on to you.
Thank you very much, Dr. Jyoti. We can definitely start a movement, but to see whether something is realized, I do not know. We definitely started making voice about the occurrence of anemia about 2 decades back, but I think we have on that end also. But now that India anemia free, we found that as far as the thalassemia is concerned, this is also a big problem. In fact, not only that, tuberculosis, genetic disorders, this is hemoglobinopathies is also a big problem as far as
Madam,
3 crore people are there with the thalassemia. And as you said, that a single child should be born in with a thalassemia major.
Shivam, I think
network issue.
Yeah, I'll just ring up Madam and tell her once. She'll just join in through the phone.
Recorded.
Hello?
Can you hear me?
Yeah, we can hear you now, ma'am.
Okay. I wish you had started, you had asked Dr. Achla to take over from me. But what I feel is, 10,000 thalassemia major children are born in this country every year. And the elimination cannot be there, I find beta thalassemia, something like 3 crores of people are there. It's a silent way they are living with a normal life, but when then 2 thalassemia minor marry together, then the problem comes of thalassemia major. And transplantation is far away as far as every person who is having a problem to have it. But I think, we require awareness about the screening during the school and the college, and probably during the antenatal period, because we find that so many, at least in my life, I have found 3 patients, 3 couples, both with a thalassemia major, have troubled me. When they come to pregnancy, planning pregnancy, you find that every time they went for analysis, it was always thalassemia major. So it's a torture getting terminated one pregnancy after another. And I think the last one was, we did a cesarean section during the COVID times, and she survived that particular time, but 15 days later she succumbed to COVID, leaving 2 children behind, and I feel very sad about it. I think something really need to be done as far as the screening and awareness is concerned. We are far away to go, but I think we should never lose hope. There are many countries who have eliminated it altogether. I'm sure we should be also able to do it. So with these particular remarks, I will ask our colleague, Dr. Achla, to say some things.
So thank you so much, madam. And definitely this is setting the right context and setting the right tone for the webinar. That's the awareness. And with this, I would request Dr. Achla Batra. She's a lady who's actually paved a really new path for AOGD as a president of AOGD, with her patience, her compassion, her humbleness, and a focused vision. We have known her to be one person who's really dedicated and has put in her all to take care of the thalassemic children and the thalassemic women. We have seen the walkathon that she had done, and even in the NACHI meeting, I think it was at the end of the day, we had a presentation by the thalassemic children. So really, I would like you to speak to us, inspire us, and really bring about the true belief about how we can take care of the thalassemic patients.
Thank you for the kind words. Having talked about awareness, but we do have children who grow up to be women and who grow up and they get married and they have children. And it is high time we knew how to take care of these thalassemic girls during their adolescent, their gynae problems, their problems during pregnancy, because we should be committed to give them good quality of life. And treating or managing a thalassemic pregnant woman is very different from managing a normal pregnancy. And probably most of us are not aware of it. First of all, the preconception period is very important. Then for them during the pregnancy, their chelation would be, decreased or change, and they will get endocrinopathies, diabetes, and thyroid, and their bones are weak. So they have lots and lots of problems. And if they are courageous enough that they are living a normal life, it is our duty that we give them good care during their pregnancy, and not just, that she's anemic, let her have blood, and that is not the end of care of a pregnant thalassemic woman. And I'm sure, except for the people who are there for the webinar today who've read about it, most of us do not know much about the care of the thalassemic pregnant woman. So I think this is a very, very good webinar, and I feel very passionately about thalassemic children, girls and women, and I'm always there to do anything for them, whatever required. Thank you.
Thank you so much, Dr. Achla. And with this, we move on to our webinar, and we really do hope that we are able to cover up both the points on the awareness as well as the management of the pregnant women with thalassemia. And I would now like to introduce the two masters of our ceremony, the masters of our ceremony today, and that's Dr. Seema Gupta. And can I have a CV? But all I can say that she's a very valuable member of the East Gynecologist Forum. She's the director of Dr. R.B. Gupta Medical Center. She's a treasurer of the Delhi Gynecologist Forum East, recipient of the DGF APJ Abdul Kalam Appreciation Award, and several other awards during her career. She has been indeed a true asset for us and for this webinar too. And the other MOC is going to be Dr. Neha Kapoor. She's a young, dynamic member of the QI committee as well as of the East Delhi Gynecologist Forum. She's an associate consultant at Cloud9 Patparganj and as well as at the Kapoor Medical Center, a girl who's very dedicated and committed and who always stands up wherever time we need her to be there. So I hand it over now to Dr. Seema to carry over the session.
Thank you, ma'am. Thank you so much. Very good afternoon to all my seniors and a warm welcome to all the delegates. Now, starting with the first session of the evening, the first topic is thalassemia, understanding the why, prevalence and pathophysiology. And the speaker for this session is Dr. J.S. Arora. I would first like to invite the chairpersons for this session. Neha, please. Can we have the CV, Neha?
If never you are having
just give me 1 second. I'm having some trouble. I can't open the Zoom only.
So maybe Shivam will do that.
Yeah,
Yeah, it's there. Thank you. The first chairperson for the session is Dr. Nija Batlaman. She is the professor and head department of Obs and Gynae at the prestigious All India Institute of Medical Sciences. She is the Shobha S. Wenger Distinguished Professor of Gynae and Oncology. She's the council member, Asian Society of Gynae Oncology. She's the member at WHO Advisory Group for Cervical Cancer Elimination. She's been on the chair for many other national, international associations. She's a very good teacher, editor of the international edition of Jeff Coates' Principles of Gynecology. She's authored many books and has written many chapters in various international and national journals. Welcome, ma'am. Then we have Dr. Jyoti Agarwal. She's a MBBS MD, all throughout gold medalist from the Lady Hardinge Medical College and Chandigarh PGIM. She's a senior consultant director at Life Care Center, Life Care IVF. She has been the past president of Delhi Gynae Forum East. She's the treasurer Delhi Gynae Forum, and she's a Delhi Gynae Forum certified trainer for infertility, IVF, ultrasound, and colposcopy. She has received many awards and for her good work. Welcome, ma'am. Then we have the speaker. Neha, Dr. Arora, slide, please. We have Dr. J.S. Arora. He's MSc in Hematology. He's been the General Secretary of National Thalassemia Welfare Society, Federation of Indian Thalassemics. He's in the member Ethics Committee, IIT Delhi, UCMS, Chacha Nehru Bal Chikitsalaya, and many other societies. He's in the Ethics Committee of many other societies also. Welcome, sir. Waiting forward to listen to you. I now invite Dr. Jyoti Agarwal, ma'am, to invite the speaker and start the session.
Thank you, Dr. Seema. Thank you so much. At the outset, a very good afternoon to all of you. Dr. J.S. Arora is not new to this forum. We have heard him earlier also. And all of us are a big fan of Dr. J.S. Arora. What I would just like to say, Dr. Seema has already introduced him. And today he will be discussing about why the prevalence and the pathophysiology of thalassemia. We welcome Dr. J.S. Arora. Dr. J.S. Arora has started sharing his screen, I suppose. No. We welcome you, sir. Please start sharing your screen.
Thank you, madam. First of all, I'll thank to this Foxy and AOGD for giving me a regular chance. I will say this is not the first time. I'm regular on your speaker on thalassemia. I think this is giving me a chance to spread the word of thalassemia among all the gynecologists, and I hope that things will improve. And without wasting much time, let us start with today's session. So, as you know, what is thalassemia? Thalassemia is not just the low hemoglobin. It is beyond anemia, and it is much more important than simple anemia of pregnancy. You have been dealing with the anemia of pregnancy very regularly, so it is much more than that. See, it is a serious inherited disorder presenting severe anemia. Formation of adult hemoglobin is absent, inadequate, or abnormal. Life of red blood cells is shortened, leading to severe anemia. It is caused by either a genetic mutation or a deletion of certain key genes. Inheritance of thalassemia is autosomal recessive. Thalassemia syndrome consists of alpha thalassemia, beta thalassemia, sickle cell disease, HB, E, C, D, Q, and various permutation combinations of all these disorders. If we talk genetically, adult hemoglobin molecule is formed by symmetric pairing of alpha and beta globin chains with iron porphyrin molecule in the center. In thalassemia, synthesis of either alpha or beta chains is reduced, resulting into shortened survival of RBCs from normal 120 days to less than 15-20 days only, leading to severe anemia. Alpha thalassemia is of two types, alpha 0 and alpha plus. Alpha 0 is severe variety. Homozygous alpha 0 thalassemia is not compatible with survival and is known as HB Bart's hydros fetalis, which you all know it. Alpha plus is mild and its inheritance is not of much clinical significance. In India, alpha plus is more common. In beta thalassemia, there is defective synthesis of beta chains and manifestations are due to alpha chains. In our country, since beta thalassemia is more common, so when we talk of thalassemia, it is known as beta thalassemia. My slides not moving. Yes, just that. Okay. This pathophysiology of thalassemia. See, there can be two, beta plus and beta 0. If there is reduced production of beta chains, it is called beta plus. And it is, if it is there total absence of beta chains, then it is beta 0. In both these conditions, there is excess of alpha chains because the pairing is not common. And because of alpha chains, the membrane damages the peripheral RBCs, leading to hemolysis and thus anemia. On the other hand, in the bone marrow, there is precipitation in the RBC precursors within the bone marrow. This premature death of RBC precursors and ineffective erythropoiesis. All these conditions lead to anemia. And this anemia leads to erythropoietin, increased erythropoiesis. There is expansion of bone marrow, and that causes a skeletal changes, hypermetabolic state that we have seen the typical thalassemia faces. That is the protruded forehead, or you can say skeletal bones of the maxilla and the dental bones. There is increased iron absorption because of anemia. And when we give blood transfusion to treat this thalassemia, that also rises iron overload in the body. That leads to liver cirrhosis, endocrine dysfunction. Thalassemia is primarily of two types. Leaving aside the thalassemia minor, there is thalassemia intermediate and major. Major is called thalassemia, transfusion dependent thalassemia, and intermediate is NTDT, that is non-transfusion dependent thalassemia. In transfusion dependent thalassemia, the blood iron of blood, because of blood transfusion, with every unit of blood, around 200 to 250 milligram iron goes inside the body, and there is a very fast increase in the iron over the body, and that leads to pituitary dysfunction, hypothyroidism, hypoparathyroidism, cardiac cirrhosis leading to arrhythmias, heart failure, liver fibrosis, cirrhosis, hepatocellular carcinoma, diabetes, hypogonadism, and bone disease. All these occur due to iron overload. But in NTDT, though the iron overload is because of increased iron absorption, so it is slow. But this also leads to silent strokes, hypothyroidism, pulmonary hypertension, liver fibrosis, cirrhosis of the liver, hepatocellular carcinoma, proteinuria, glomerular hyperfiltration, hypogonadism, venous thrombosis, leg ulcers, and bone disease. What is the condition of a thalassemia major child? Thalassemia major child is when it's born, he is absolute normal, hale and hearty, like any other child. But by the age of 3 months to 6 months or so, child becomes pale, lethargic, not going well, delayed milestones, protruded abdomen due to increased liver and spleen. 90 to 95% are diagnosed within first 2 years of life. And the only treatment is repeated blood transfusion every 2 to 4 weeks, repeated injections, hospital visits, investigations, iron chelation, and cost of therapy is around 50,000 to 2 lakh per year, which is beyond the means of any even upper middle class family. The permanent cure bone marrow transplantation is very costly, risky, and not feasible because unavailability of the HLA matched donor. There is always fear of transfusion-transmitted infections, even though every blood unit is tested for this hepatitis B, C, HIV, and malaria and VDRL. But still we see patients with hepatitis B, C, and HIV because of repeated blood transfusions. There's a loss of time, energy, money, endocrine complications, liver, heart failure, and always fear of death. This is a story of a 30-year-old thalassemia girl. She has already received 840 units of blood, 16,800 injections of Desperol for iron chelation. For that, she has to take needle in her body for over 72,000 hours. You can imagine that. And spent 33,60,000 only for the iron chelation. You can imagine it, a mother, when the mother wants to get the child in her lap while sleeping, she has to, or father has to prick the needle daily night to give just for injection to take out extra iron. We expect her to cross around 60 years of age with the present treatment. Then she will require another 1,000 units of blood, 20,000 injections, that is 1.2 lakh hours of needle in her body, and around 40 lakh rupees required for the Transfusion therapy. Since her father was having CGHS beneficiary, so she could afford that treatment. Otherwise, it's very impossible for a person to afford such a costly treatment. It is not, sorry. So this is the family life of a thalassemic child. You can imagine the running from pillar to post, the blood transfusion, investigation, hospital visits, and how hodgepodge is their life. You can imagine from this caricature. It is not a disease of few people. The prevalence is very high. It is 1 to 17%, around 3.9% on average in India. 10,000 to 12,000 Thalassemia Major born every year. Sickle cell disease is common in tribes, and in some tribes it is as high as 40%. HBE, which is also a type of beta thalassemia, a variety of beta thalassemia, it is highly prevalent in West Bengal and Northeast states. Alpha thalassemia, I told you, it's not significant. According to ICMR, 1 out of 18 is in Delhi is a thalassemia carrier. You can imagine the high incidence rate in Delhi itself. And 5 crore Indians are thalassemia carrier. And 1 thalassemia major child every 45 minutes. I think before 2 of us finish this lecture, I think there will be having another 2 thalassemia children in India. This is how thalassemia is passed on from parents to children. See, when the one of the couple is not a carrier and other is a carrier, there is 50% chance of having a thalassemia carrier child, but none is affected. But if mother and father both are thalassemia carrier, then 25% chance of having a thalassemia major child, 50% carrier like parents, and 25% non-affected. Since now we are talking recently on this session itself, we'll be talking on pregnancy of the thalassemia major children. So we are getting couples now, thalassemia major boy or girl going for marriage. So in that case, if one of them is a thalassemia major and the other is a carrier, then 50% will be thalassemia major and 50% carrier. We have seen many thalassemia major boys and girls marrying each other as a life partner. In that case, if they plan pregnancy, then every child will be thalassemia major. So if both parents are thalassemia carrier, then each pregnancy carries a risk of 25% of having a thalassemia major child. Thalassemia is preventable because, as Dr. Shardajan told us, that many countries has eliminated thalassemia from their map. If we talk of this Cyprus, Sardinia, Greek, and Italy, Thailand, etc., Cyprus started thalassemia control program in 1974, and within 10 years, by 84, their thalassemia major born was zero, almost zero. And in Sardinia, Greek, Italy, they reduced by 90% in 10 years. So most successful control programs are based on carrier detection, counseling, and fetal diagnosis. How to diagnose thalassemia carrier? It is really very simple. So it's unfortunate to note that all the doctors, not only I say gynecologists, everyone, being a physician or any, maybe even IENT cardiac, they can just suspect thalassemia carrier status by looking at CBC. Usually what we do is just look on the hemoglobin level, TLC, DLC, platelet, that's all. If we see MCV and MCH, if MC less than 80 and MCH less than 27, that denotes either iron deficiency anemia or you can say beta thalassemia trait. But if we go also see RBC count, if there is iron deficiency anemia, then RBC count will be also low. In the thalassemia trait, it will be high. So look, and RDW will be high in iron deficiency anemia, and while normal or maybe slightly high because of concurrent this iron deficiency anemia, it may be slightly high. So, for example, I tell you, if a person having a hemoglobin level of 10 gram and his or her the RBC count is 4, it's okay, maybe iron deficiency anemia. But why a person of having hemoglobin 10 gram should have RBC count 5.5 million, or even a hemoglobin level of 13 gram and having a RBC count of 6 gram? You must suspect that he or she may be a thalassemia carrier. So confirmation is done by HbA2 estimation. It is by either HB electrophoresis, or these days we have HbHPLC very easily available. If HbA2 is more than 3.5%, it is a confirmed diagnosis of thalassemia carrier. There are many indexes available, like Mensa is quite simple, but since all these indexes are not true, you cannot rely, they are not reliable. So we don't depend upon that. We just look MCV, MCH, RBC count, and then we can advise HbA2. So thalassemia test needs to be just once in lifetime. Why not to get it done as early as possible? Here I like to request you, even we don't have to wait till the lady comes for you for the pregnancy, for antenatal checkup. When the girl comes to you around, say, 12 years, 13 years, 9 times they come for their periods or other things. Even then, by looking at CBC, if you can advise thalassemia carrier status, that would be good. And even not only gynecologist, even a general physician should also come forward by looking at CBC, because CBC is done so frequently in almost every condition, every infection. We go for CBC and we should go for thalassemia carrier status. I'll give you 2 examples here. This is first case, that is, you see, hemoglobin is 11.5 gram and MCV is 88.8, MC 28.5, A2 is 2.3. So the person is not a thalassemia carrier. While in other case, where HB is 14.2 and you see MCV is 61.2, MCV is 20.5, while A2 is 5.3. So you see the HB 11.5 may not be a carrier, while 14.2 may be a carrier. That is why I always say anemia is no criteria to diagnose thalassemia. Even males from 11.5 to up to 15.3 can be a carrier, and females up to 14 gram can be a carrier. I like to repeat this slide, reason being, I have seen many gynecologists, many persons, when they are told to go for thalassemia carrier status, they say, okay, your hemoglobin is very good, you don't require thalassemia carrier status. So never rely on hemoglobin level, go either by MCV, MCH, or you can advise everyone if she is coming for the pregnancy antenatal checkup. So there are some fallacies in the HbA2 estimation as well. If there is concomitant iron deficiency, it lowers HbA2 level. Silent beta thalassemia trait may also have may not have elevated HbA2. It may be low in that as well. Coexistence of alpha thalassemia will also have normal level for HbA2, and even delta beta thalassemia may have normal or low level of HbA2. Just a minute. Okay, here you see less than 3.1 HbA2. It will be either normal or maybe having alpha thalassemia trait. 3.1 to 3.9, either beta thalassemia trait with iron deficiency anemia or beta thalassemia trait with alpha thalassemia. So if you look at 3.1 to 3.9, or especially between 3.1 to 3.5, never consider that the person cannot be a thalassemia carrier. Then we'll discuss the next slide. 3.9 to 9 is beta thalassemia trait, and if it is more than 9%, it is HbE syndrome. So if one partner is thalassemia carrier and other is borderline HbA2, always ask for mutation analysis by gene sequencing, so that you don't miss any case, because silent you will miss either because of concurrent alpha thalassemia or because of silent beta thalassemia gene. So in 1925, thalassemia was described by Dr. Thomas Cooley, also known as Cooley's anemia. 1970, prenatal diagnosis of beta thalassemia first time accomplished by globin chain synthesis analysis on fetal blood obtained by placental aspiration at 18 to 20 weeks of gestation. 1990, prenatal diagnosis of beta thalassemia was available at Bombay and AIMS, New Delhi. But what happens in 2012? Two gynecologists in Delhi, I repeat, in Delhi, did not advise HPLC in first trimester. And the lady delivered a thalassemia major child, which was really unfortunate. So how to prevent thalassemia major in the child? Screen every pregnant woman on first visit. If she is positive on screening, confirmed by HbA2 estimation, by HB electrophoresis or HPLC of the husband as well. If husband not a beta thalassemia trait, no further action required. If husband is trait, it needs prenatal diagnosis. If fetus is thalassemia major, they can terminate a pregnancy, which is legal. If it is beta thalassemia trait or normal, then continue the pregnancy. Indications of partner screening of and prenatal diagnosis. See, if the lady who approaches to you, if she is beta thalassemia trait, delta beta trait, HBS trait, D trait, or D thal or tau thal, the partner must be screened for thalassemia status. And if it is borderline for a partner, then they should advise for a genetic analysis by sequencing. So prenatal diagnosis is required if both are thalassemia trait. One is thalassemia trait, other is E trait or E homozygous. E trait, one is a thalassemia trait and that is sickle trait, both sickle trait, sickle and HBD trait or homozygous, delta beta trait and beta thal major, and beta delta and beta thal major, any combination that you require prenatal diagnosis. Prenatal diagnosis is not required in a couple where both partners are HBD trait or homozygous, both partners are HBE trait or homozygous, and one partner is HBQ India and other is thalassemia trait. So this is your domain. Then if at all you have a couple thalassemia carrier, both couple, then you have to go for all these things, which is better known to you. And if I ask the cost, it is zero at Lok Naik Hospital in Delhi, around 2,000 to 4,000 in AIMS, SGPI, and PGI Chandigarh, around 20,000 to 40,000 private setup, and PGD 3 to 5 lakh rupees. So then whenever a obstetrician or gynecologist delivers a lady, she hands over this beautiful children to the family. You can imagine कि आप उसकी खुशी का मतलब वो इजहार नहीं कर सकते, कितने खुश होते हैं, आप पहचान सकते हैं उनको. लेकिन कभी कभी जब उन बच्चों में से कुछ ऐसे बच्चे आ जाते हैं जिनको ब्लड चढ़ाना पड़ता है, तो आप उनकी निराशा का भी अंदाजा लगा सकते हैं. So you can imagine when you are giving how much this happiness to the family when they are delivered, and after 3, 4 months, 6 months, when these things happen, and you can imagine their state of mind. So take home message. Do not forget to add HbA2 HPLC in your test list advised to pregnant women on first visit. And here, though I don't want to, but I have to say that once a thalassemia major is diagnosed, family starts cursing obstetricians for not advising thalassemia test. वो आपके सामने नहीं कहते, लेकिन हमारे सामने बहुत कुछ कहते हैं. तो मैं ये I would like to share this because you should know. कहते हैं ना कि सामने तो सब लोग प्रशंसा करते हैं, पीछे कोई ऐसा ना कहे, तो वो भी नहीं होना चाहिए. That is the reason I am sharing this attitude of the patients. So जैसा कि डॉक्टर ज्योति ने शुरू में कहा कि I don't want another new thalassemia major should born from our side. तो मैं आपके लिए यही मेरी बात को डॉक्टर ज्योति भास्कर पहले कह चुके हैं. Let us take a thalassemia शपथ today कि मैं कभी भी थैलेसीमिया बच्चे के जन्म में कारण नहीं बनूंगी एवं अन्य चिकित्सकों को भी इसके लिए प्रेरित करूं. मैं इसके लिए आप इसके साथ आपको धन्यवाद करता हूं. थैंक यू मैडम.
Thank you so much, sir. Thank you so much. And now I welcome Dr. Nija Batlaman and ask her to give the concluding remarks.
Thank you very much, Dr. Seema. It has been such a wonderful talk by Dr. J.S. Arora. I really compliment you, sir. What a wonderful, comprehensive. You have looked at every aspect of the problem. You have highlighted the social issues apart from the medical.
So I think it has been a great session which has opened everyone's eyes, I think, as to exactly what is the problem and how it is to be best managed and what is the way forward. So I think especially I really liked to hear that story of the Thalassemia Major pretty girl. Wonderful story, but look at the pain behind her smile. So I think it is true, it's a different world. A lot has changed, that we can actually see these patients reaching adulthood and able to fulfill their dreams. That is a very big thing, actually. And that we are able to help those who have this affliction to achieve. You are very right, there's an immense input that goes into it, but at least now they have a life that is meaningful, and that they can even live to motherhood is something that was not even thought possible like 2 decades ago. So we have witnessed this whole change because of the whole movement in blood banking, the component therapies, and so many things have happened to multifold enhance the availability of blood also. So many things are there. So you have brought it all together very well in a nutshell. I'm sure there will be many questions, and we would request our audience to post them in the chat box. And thank you so much for inviting me to be chair to this great session.
Thank you, madam.
Thank you so much, ma'am.
Thank you so much, sir, for such an informative talk. I learned so many things today, and I would just like to stress the main thing which I have learned today is anemia is no criteria to rule out thalassemia. So we should not go by an idea कि ये तो anemic नहीं है, तो इसको HB electrophoresis कराने की जरूरत नहीं है. We should routinely get it done at the first visit itself, because earlier we get it done, the better it is. We have an option to terminate pregnancy in case required. Sir, I would just like to know, suppose a baby is born to a couple, one of them is a carrier and one of them is normal. At what age do we get the testing done for the baby to rule out that whether the baby is normal or thalassemic minor till that fetal circulation is settled or whatever?
See, when one is a carrier, others not a carrier, child will never be a thalassemia major.
Yes, true.
If it is major, then the other person is silent carrier. So there is some misdiagnosis at the partner level.
Okay.
And if you want to confirm that the person is not a thalassemia major at all, then even at the say at the time of birth, the fetal hemoglobin is around 80% or so. By 3 months or 6 months, it comes down. At the age of 1 year, it is less than 1%. So that we check only in those cases where we have done PNDT, where we have done diagnosis, and we want to confirm that whether our diagnosis is correct or not. Then at times we advise them to go for this HbF testing at the age of 1 year.
So once the child has crossed 1 year, that is the right
Yes.
time to see whether the child is normal or a carrier. And one more thing, sir, I would like to know, many a times diabetes is also very common in our country. And what I know that the testing of if the diabetes is uncontrolled or very high, many a times HbA1c does not give us a proper report. How do we go about in these cases?
For diabetes?
Yeah, for diabetics,
Okay.
Uncontrolled with very high HbA1c, almost 10, 11, something like that.
Right. See, in thalassemia carrier, there is no difference like any other person. Thalassemia carrier, diabetic, all parameters are equal. There's no change at all. While in thalassemia major, we don't rely on HbA1c. And many times good labs don't report even HbA1c. Because if they find there is a high fetal hemoglobin or abnormal hemoglobin is there, they don't report HbA1c. Many of our patients are having diabetes. Then we advise either blood sugar fasting PP or fructosamine, not HbA1c. HbA1c is not reliable in thalassemia major because of repeated blood transfusions.
Okay, thank you so much. Thank you.
Thank you so much.
Dr. Arora,
Thank you.
Dr. Arora, I
Please.
just wanted to know this prenatal diagnosis is only available at LNJP free and at some caste and aims. So there are so many people who will not be able to avail this for the want of money. So is your society doing, like we have so many Janani Suraksha Yojana and so many other things, is your society trying to motivate the government that these families should be given money for getting this test done if
Yes, madam. I have listed only few centers because we are living in this part of the country. So especially zero was because of LNJP zero. Even AIMS, PGI, Lucknow are around 2000. That doesn't matter. And there is even CMC below is there. In Chhattisgarh government that is giving this cost reimbursement for this prenatal diagnosis. Even Gujarat government is doing free of cost. So many states are doing, because I mentioned only this part of the country. So there it is available in other parts of the as well. But there are few. I must say it is not in every city or every major city, but there are few. Gujarat it is almost free. In Chhattisgarh they are giving free. It's CMC floor. It is below. It is very economical, and maybe some other states as well. And those who cannot afford it, and even LNJP, Dr. Sangeeta Gupta is here. She is too willing. She's very always ask us to, if at all anybody requires the prenatal diagnosis, sent to us. And she's very cooperative, always helping us. And as Dr. Deka was doing earlier the AIMS, so now we have got another champion, Dr. Sangeeta Gupta, with us.
Thank you.
Thank you so much, sir. I think we can have the question answers after the second session, or maybe at the last.
Welcome.
We can go to the next session. The second session is on thalassemia management in pregnancy by Dr. Sangeeta Gupta. And the chairpersons for this session are Dr. Professor Deepika Deka ma'am. She's a fellowship, MD, Obs and Gynae, and fellowship in maternal fetal medicine from WHO USA. She's a senior consultant fetal medicine at Cloud9 Hospital, Gurugram. She's also the president of the Delhi Gynae Forum Dwarka branch. She's the former professor and unit head of obstetrics and gynae at the All India Institute of Medical Sciences. Welcome, ma'am. She's also welcome, ma'am. Then we have Dr. Mala Srivastav. She's a senior consultant and professor at Gripmar, the Sir Gangaram Hospital, gynae endoscopic and robotic surgeon. She's the vice president-elect of ISOPAP 2023-24. She's been the immediate past president of AOGD. She's a gynae oncology, gynae endoscopic surgery, and gynae robotic surgeon. Welcome, ma'am. And I request Dr. Mala ma'am to please introduce Dr. Sangeeta Gupta, the speaker for the next session.
Thanks, Dr. Seema. It's my privilege and pleasure to introduce the speaker, star speaker of the day, Dr. Sangeeta Gupta. Dr. Sangeeta is Director Professor Obstetrics and Gynecology, Maulana Azad Medical College, New Delhi. She has established fetal medicine clinic at MAMC and LNJP Hospital, and she has vast experience in invasive procedures. She had been awarded Commonwealth Scholarship and trained in fetal medicine at St. George's Hospital, London. She is faculty at FNB training program on maternal fetal medicine, expert with NBE and UPS, member of WHO, multiple publications and contributions to various textbooks. She had been secretary of NARCHI, editor of AOGD Bulletin, joint secretary AOGD. She is very, very academically oriented, and we are waiting to hear from you. Dr. Sangeeta, it's over to you.
I would like to welcome Dr. Sangeeta. Want to listen to your talk. I just want to give a little introduction to the management of thalassemic women in pregnancy. So as Dr. Arora said, we have two types of women, carriers and major. You know, it was unheard of that women with thalassemia major would conceive. We also have another group of women who are called thalassemia intermedia. They do not receive blood transfusions every month, but may require transfusions once in every 3 or 4 months. So at AIMS, we have the opportunity of managing such cases. And even in Cloud9, just the other day, I had a case of thalassemia major who wants to conceive. Very interestingly, her hemoglobin is about 12, 13, and she's on regular blood transfusions. What she very wisely decided, very brilliant girl, that she will have a surrogacy. You know, so that was one very nice way out, so that she would be not having all the complications of pregnancy, anemia and all that, but it will be her own baby. But of course, there has been a lot of, problems and not knowing how to manage a case of thalassemia minor, because they do get into have the physiological anemia on top of that. So Dr. Gupta, Sangeeta, it will be very interesting to see. and to really update how women with thalassemia minor, I think that's what you're going to talk about more, should be managed during pregnancy. Over to you, Dr. Sangeeta.
Good evening, everybody. And first of all, I would like to thank the Delhi Gynecologist Forum and the QI subcommittee of AOGD for inviting me here. The passion for thalassemia of Dr. J.S. Soda was quite obvious from his talk. And sir, I thank you for your kind words. And so to Dr. Mala Arora and Dr. Dekka. And I feel most honored that Dr. Dekka is chairing this session for me, because I can never forget the person who had held my hand when I wanted to learn fetal medicine. She's the first person to hold my hand. So
it's been a pleasure.
This is the right moment to recall those lovely days. So with that, I come to the topic of today, thalassemia management in pregnancy, balancing iron and blood, which is really a tricky situation. I'll only restrict myself to the management of this aspect of thalassemia in pregnancy. So I would be broadly discussing about blood transfusion in these women, iron chelation therapy, iron therapy, and just a little word about erythropoietin. So majorly we'll be covering here beta thalassemia, in which we have a beta thalassemia major, which has already been defined, where the patient receives more than 8 transfusions per year. Beta thalassemia intermedia, where there are very infrequent transfusions, maybe never, except in pregnancy, she might require transfusions. And then we have minor, which is the most common, and the commonest presentation is a mild anemia, the microcytic hypochromic type. Now, coming to women with thalassemia major, this has already been briefed by Dr. J.S. Arora, but just to complete the perspective of my talk, there are 2 important aspects. One is hemolysis, and the other is the chronic hyperperfusion. Now, hemolysis leads to severe anemia, which is also contributed by ineffective erythropoiesis in these women. There is hypoxia, which leads to FGR. There is also pulmonary hypertension and congestive cardiac failure, and increased risk of thrombus formation because of the defective RBCs in circulation, splenectomy. And this is more common in individuals who have very infrequent transfusions, because patients who have transfusions, their blood gets diluted by normal RBCs. Now, as far as chronic hypertransfusion is concerned, iron overload is the greatest challenge, which damages almost all organs of the body, most predominantly the cardiac, the endocrine, and the liver. There is a risk of alloimmunization because of repeated transfusions, and this further causes anemia because of hemolysis. And of course, we all know the risk of transmission of infections. So my talk will be, around these aspects. So, of course, one can't manage a woman who's a thalassemia major pregnant without a multidisciplinary approach. And I think the most key person in this team is the hematologist and the transfusion medicine specialist besides the obstetrician. And these women do require a evaluation by a cardiologist, an endocrinologist. Geneticist, again, a very important part of the team if a prenatal diagnosis is required, and a hepatologist. Planning and follow-up is right from the preconceptional area to the postnatal period, though one may need to individualize the treatment for every patient. So coming to blood transfusions, in the women who are thalassemia major or intermedia, the desirable pre-transfusion hemoglobin during pregnancy is 10 gram%. This is essential for optimal fetal growth, because it has been observed that women who have a hemoglobin less than 10 gram% usually suffer from growth restriction. The indications of transfusions would be whenever the hemoglobin falls below 10 gram%, or there is a associated growth restriction. And the target after transfusion is usually 12 gram%. And you have to monitor these women every 2 to 3 weeks. Now, if a woman with thalassemia major is there who comes to you at 36 weeks, a woman, particularly the intermedia, who comes to you at 36 weeks, has not been transfused so far, is 8 g%. One can avoid the transfusion pre-delivery, and sometimes erythropoietin has been tried alternatively, and the blood is given in the postnatal period if it is required. Now, if the hemoglobin is less than 8 g%, then there is no other option. So, though in beta thalassemia major, our objective is to minimize transfusions during pregnancy to prevent the iron overload. However, this is not possible, and what has been observed is that the requirement is increased. So it is in this situation where balancing iron and transfusion is really the challenge. As far as beta thalassemia intermedia is concerned, they may require transfusion for the first time during pregnancy. Now, both these situations are associated with the risk of alloimmunization, which further worsens the anemia. This increases with multiple transfusions and is more commonly seen in women who were splenectomized. So to bail out of this situation, to prevent this alloimmunization, an extended red cell antigen typing is very, very important, as it improves the safety of transfusion. And this is here where the role of a very good blood bank and a transfusion medicine specialist is there. So one should resort to this extended red cell antigen typing, particularly when a patient receives repeated transfusions or one requires massive transfusions as in obstetric hemorrhage. As far as beta thal trait or minor is concerned, one usually doesn't require transfusion unless she has severe anemia. Now, we are all aware of the transfusion-acquired infections, predominantly HIV, HCV, HBV, and cytomegalovirus. And for the prevention of this, one should resort to voluntary donation and screening for infection in donors and the donated blood. The mothers should be screened, and the spouses who are beta thalassemia major, who are receiving transfusions, should also be screened. Ideally, this should be done preconceptionally, though if you can't catch them there, please don't forget to do it in the antenatal period. And it is very important to screen these newborns because there may be vertical transmission of these infections, and immunize whenever appropriately. Now, next I come to the chelation therapy, because this is how you're going to balance the blood transfusion and the iron. So Dr. Arora has just talked about chelation therapy, that this chelation therapy is administered to overcome the iron overload. So it is ideal that a preconceptional complete evaluation of organ iron overload should be made. And in this particularly, the heart and the liver are very, very important. And an intensive pregestational chelation is done to optimize body iron burden, because this helps in preventing diabetes mellitus and cardiomyopathies particularly. So what is the preconceptional optimal iron levels? The weight iron levels, we primarily estimate them in the myocardial iron concentration by the cardiac T2 MRIs, and we want a T2 value of more than 20 milliseconds for the myocardial iron concentration. And for the liver iron concentration in the liver scan, the T2 should be less than 7 milligram per gram dry weight. So these figures are very important. Ideally, women should come to us in the preconceptional period, and these are the two estimations which we make to assess their iron overload. The other important thing in the preconceptional period is that oral iron chelators are potentially teratogenic and have to be stopped minimum 3 months prior to conception. And one should change to desferoxamine preconceptionally. Now, the desferoxamine cannot be given orally, has to be administered either by subcutaneous, primarily by subcutaneous or intravenous route. So that's the challenge there. But it is very important, one, to do an intensive pre-gestational chelation to bring down the iron load, and number two, the drug which we are going to use. Further, carrying on chelation. So now once you have put the woman on DFO preconceptionally, you must stop DFO as soon as pregnancy is concerned. The dictum usually is that one should avoid chelation during pregnancy, but it is not possible in patients of thalassemia major who are receiving such a high number of transfusions. So in the first trimester, one should immediately, as soon as you confirm the pregnancy test, you should stop the chelation. Though it can be started in the late second and the third trimester, if the benefits outweigh the risks. So if your MRI demonstrates a significant increase in the cardiac T2, that is the levels fall to minus 10 milliseconds, or on your liver scan, you have T2 of more than 15 milligram per gram dry weight. So these are two important markers where one might have to consider chelation in late pregnancy. Now, again here, desferoxamine is the chelator of choice during pregnancy, though the teratogenic effects have not been validated so far in good studies. However, its large molecular size prevents the passage through the placenta, and so many studies so far have confirmed that there have been no adverse effects either on the baby because of desferoxamine. And as already told you, that oral chelators are contraindicated during pregnancy. They fall in the category D drug, and there are concerns about teratogenicity. Now, this is not where chelation stops. Particularly in women who are thalassemia major, one has to cover the period of labor also with chelation. You have to give IV desferoxamine 2 gram over 24 hours, which has to be administered for the duration of labor. And further down in the postnatal period, as you have to resume chelation after delivery. So here you are going to stop the IV desferoxamine and go to the subcutaneous administration. It is not harmful for the newborn, though it is secreted in the breast milk, as it is not absorbed by the infant gut. And oral chelators are again contraindicated during lactation, and one can only switch over to oral chelators once breastfeeding has been, or lactation has been stopped. In fact, it has been observed that some women abandon breastfeeding very early simply because they have to take oral chelators. Now coming to the iron therapy, and I think this is what Dr. Decker wanted me to talk. So iron therapy in patients of beta thalassemia is something which can only be given in thalassemia minors. There has been a lot of debate on this issue. We have a misconception that no iron can be given to a patient who's a thalassemia, even if she's a minor, or we restrict ourselves to giving only the prophylactic dose, that is just 1 tablet of iron per day. The third misconception, which is very usual in our practice, is that many of us are giving this prophylactic iron to all beta thal minor women who become pregnant. So now, talking about beta thal minor, these women definitely become more anemic in pregnancy simply because of the hemodilution and the inability of these women to, increase their erythropoiesis. So, however, beta thal minor is not associated with significant maternal or fetal morbidity during pregnancy. Now, there is significant coexistence of beta thal minor and iron deficiency anemia. And this is very, very important to pick up. This can only be detected by doing the serum ferritin levels. And I have shown 2 ferritin levels. The upper ones are 3 studies from India itself, where people have seen that if serum ferritin levels of less than 15 nanograms are present per ml are present in a woman who's a thalassemia minor, this is diagnostic of a coexistent iron deficiency anemia. Whereas from the Western world, particularly the British studies, they have quoted a level of less than 30 nanogram per ml. So now, it is very important to remember that iron supplementation should be only given in thalassemic minor women when there is a proven iron deficiency anemia, which is done by serum ferritin levels, in contrast to universal supplementation of iron in normal pregnant women. So here, supplementation can be given. However, it should only be given once you have confirmed that there is coexisting iron deficiency anemia. This can be only detected by serum ferritin levels. And the dose, I have made it bold, you can even go up to 200 milligram of elemental iron per day. So there is no restriction of just giving her 1 tablet per day. There is lot of literature which is supporting this now, and latest one has come in British Journal of Hematology in 2022, which says that in pregnant women with beta thalassemia minor and concomitant iron deficiency anemia, iron supplementation is both effective and safe. Now, as far as parenteral iron is concerned, we are all aware that there is no, it is completely contraindicated in hemoglobinopathies. And iron therapy has, of course, no role in minor or intermediate because these women are already overloaded. Another very important aspect in this treatment is folic acid supplementation. These women require high doses of folate, which is 5 milligrams per day, because there is an increased cell turnover and hence they require more folic acid. And it has also been observed that supplementation of 5 milligrams of folic acid daily produce significantly greater increase in the pre-delivery hemoglobin level compared with the 0.5 milligrams usual dose. A word about erythropoietin, which I've already told, that if it's beta thal intermediate, particularly around 36 weeks with a hemoglobin of 8, one can go away with the blood transfusion and give erythropoietin. However, there is debated role in treatment for beta thal traits or minors, because it has been seen that there is variable efficacy and the safety data is still not complete. So at the end, my take-home messages are that screening for end organ damage and optimization of complications prior to embarking on any pregnancy is the key to favorable outcomes. Most of the friends in private sector do not face this challenge, but we in the public sector are still struggling with this, because most of our patients will only come not only after getting pregnant, but somewhere late second trimester. Cornerstones of treatment during pregnancy are safe transfusions and judicious use of iron chelation therapy. And the most important message which I want to give here today is that in pregnant women with beta thalassemia minor and concomitant iron deficiency anemia confirmed on serum ferritin levels, iron supplementation should be given, because that's the set of women we most commonly cater to. Thank you so much for your patient hearing.
Thank you, Dr. Sangeeta. I just took over quickly because I thought that maybe our obstetricians would like to know how do you manage the pregnancy, the prenatal diagnostic part. I mean, could you just add a little bit about it?
Okay, ma'am, but I think that was to come in the next session in the panel, if I'm not incorrect. So
yeah, but
yes,
I think a lecture on how to manage
both of us,
thalassemia,
this is very close to our heart. So
yeah, just outline it,
yeah,
so that there is, because I get calls every time.
Yeah.
What to do, what not to do.
Yeah, I would like, in fact, take this opportunity and take 2 more minutes. My first very important message is please stop writing hemogram. Please write complete blood count. And I think Dr. J.S. Arora has made it amply clear. Number 2 point is time is a very critical factor. The moment you pick up a woman whom you suspect hemoglobinopathy might be there, please refer her to a fetal medicine specialist or a geneticist or a hematologist immediately, because once you have picked up a complete blood count, then we do an HPLC, we need to investigate the partner, and this is not sufficient to do a prenatal. After you have confirmed that both the partners are carrier, you need to do a mutation marking. Unless you do that, you cannot do any prenatal sampling, and this takes minimum 2 weeks. This takes 2 weeks. So once you have done the mutation marking, then we take up the woman after she's 11 weeks of pregnancy for prenatal diagnosis by chorionic villus sampling. And if she happens to come later than 14 weeks, then we opt for an amniocentesis after 15 weeks. So in a nutshell, this is what I wanted to tell. And again in my every talk on thalassemia, I request everybody, time is a very critical factor, because each day the pregnancy is growing. We are fortunate that 24 weeks is the limit, but let's not forget that it's very traumatic for the mother as the pregnancy keeps going on. And it's much safer for her if you catch her in the early pregnancy. And I think Dr. Becca will fill up.
I think there will be some more questions from the audience. But before that, I just wanted to add, with all the complications for thalassemia major in pregnancy, I think there is a very important role for surrogacy for these women.
Madam, I like to just a minute.
No, I just wanted to ask, if the patient is not responding to oral therapy, can you give a little bit of IV iron therapy, Dr. Arora said last time that we can give if the ferritin levels are low.
Yes, yes. Madam, I'd like to add one more thing that we can give iron therapy IV, no problem. That depends on your ferritin level. And as Dr. Sangeeta Gupta was saying, the time is very important. So I like to add here one more thing. That is when this lady comes to you during pregnancy, then don't look for CBC. Then directly advise HPLC. CBC
Also husband.
CBC is when she comes to you pre-conception. Because every day you are losing. Then if you ask for CBC today, then report she'll come to after 3 days, 4 days. So you will be wasting time. And if possible, especially in private setup, it is very much easily possible. Or even government as well, you can ask the husband to be screened immediately. That both be screened simultaneously to save
Dr.
the
Arora, this issue is not, it's not in the public sector, private sector. Everybody in the private sector today is writing HPLC.
Yes.
This issue is more prevalent in government sector, where the women are either coming only when they get pregnant, that too they are coming late. So there you have to pick up. And then there are so many people who are not ready to spend a penny from their pocket. And then the system, you would know, they will not put up the HPLC samples till they have a particular number of samples, because the reagent gets wasted. So we have huge issues at our place, I think. That is
So
why
we are doing for everybody.
Yes,
and
Dr.
we screen husband only if some issue comes with the mother.
Yeah. No, Dr. Angela, that's absolutely. In fact, in my fetal medicine clinic, all preconceptional women, I'm straight away asking them to get the HPLC done.
Same here.
And I think Dr. Arora has made a very valid point here that once she's pregnant, time is very critical. So that's the time we should straight away go for HPLC, and sometimes simultaneously for both of them, depending on how much time is available with us.
Yeah. So another important take-home message would be, you have to be a little liberal about giving blood transfusions. You know, because there is a problem with giving iron, and it takes time. So the indication for giving blood transfusion is much higher.
Sir, madam, as far as iron chelation is concerned, see, it is better that before conception, you'd start planning 6 months or a year before, so that you reduce the iron overload before the conception. And then, because you have to stop for at least for 6 months during pregnancy, in the last trimester, you can give Desfra.
Definitely, sir.
So
You
I
have
just
rightly
want to
said,
know,
there is a role for preconceptional counseling for these women, because patients who are thalassemia major, they have been coming to the doctor every 3 months or every 2 months. So whenever they are planning pregnancy, their maternal health should be optimized before they go and take up a pregnancy. That should be an important take-home message, because these women, they are coming to a medical facility wherever they are going for blood transfusion. So each and every doctor should be sensitized regarding to the preconception counseling, and they should optimize the maternal health before they take up a pregnancy.
Yes. Another point I want to add from my practice is that obstetricians think, that you can send the patient today and tomorrow we will do the CVS. It's not like that. It's not like that. We have to do the mutation analysis, which takes, as Dr. Sangeeta said, at least 2 weeks. And sometimes you may not find it. You may not identify the mutation, and then you might have to do a cord blood sampling. So obstetricians must know that this is the next step. After you have diagnosed that the woman has thalassemia minor, the partner has thalassemia minor, you need to do the genetic testing first. And then only can you do the CVS or the cord blood sampling. There are some very interesting questions. If I may, Dr. Jyoti, should I go in for the questions?
And then we'll take the questions at the end of the panel.
Okay.
If they're not cleared by that time, then we'll do that.
Yeah.
Thank you so much, Dr. Sangeeta Gupta and all our experts. Thank you so much for your comments. Now we move on to the next session, which is the panel discussion. I invite Dr. Neha to please invite our moderators and the panelists.
Good evening, everyone. It's my proud privilege and honor to introduce the moderators and panelists for the next session. I would like to congratulate the speakers for the wonderful session. And moving on to the next segment of today's webinar, Dr. Jyoti needs no introduction. She's the principal consultant at Apollo Cradle Hospital. And besides, she is also the co-chairperson of AOGD subcommittee on quality improvement. And she's the president of Delhi Gynecologist Forum East. And besides, she is also a very gifted writer. Our moderator for the session, next moderator is Dr. Aparna Sharma. She needs no introduction. She's the additional professor at Division of Maternal and Fetal Medicine, AIIMS, New Delhi. And she has been a recipient of many awards. And she's a very humble person and is always ready to help. She's also the chairperson of AOGD Quality Control Committee. Welcoming our panelists for the session. Our first panelist is Dr. Vatsala. She is the professor at Division of Maternal and Fetal Medicine in Department of Obs and Gynae, AIIMS, New Delhi. She has over 160 papers in peer-reviewed journals, over 200 presentations in international and national conferences. She has a special interest in fetal medicine, and she has an interest in diagnostic and therapeutic interventions, including intrauterine transfusion. Our next panelist is Dr. Poonam Goyal. She is the HOD of IVF and Infertility at Max Hospital, Vaishali. She's also written many books, and she's the central executive member for Society of Fetal Medicine. Welcome, ma'am. Our next panelist is Dr. Meenakshi Ahuja. She's the director of Fortis La Femme. She's the president of Indian Menopause Society. Our next panelist is Dr. Angela. She is the director and head of Minimal Access Surgery, Fortis Memorial and Research Institute, Gurgaon. She is the director of Obs and Gynae at Fortis La Femme and the president of Delhi Gynae Forum South. And our last panelist is Dr. Swati Agarwal. She's the professor at Lady Harding Medical College. She's also the nodal officer for JSSK and Lakshya. Welcome, ma'am. Handing over to Dr. Jyoti and Dr. Aparna. Dr. Jyoti.
Dr. Aparna will start.
I was muted, so ma'am, Dr. Jyoti ma'am, you would like to start with a few words?
It's your show, Aparna.
Can't hear you.
We are the obstetricians, you are the fetal medicine. It's your show.
Okay, so very good evening to all of you, and it's been real pleasure listening to both the speakers. And Dr. Jyoti, I think you would agree with me when I say that, most of it has been covered. Right. But, somewhere when we talk about the case related issues, then we really need some kind of a reinforcement. So I will begin by a few case scenarios. And before that, we have heard enough about the hemoglobinopathies, hemoglobin structure. And why this is important is that these genes are on chromosome 11 and 16, and this is important to know from the perspective of prenatal diagnosis. Dr. Decker has also been insisting and emphasizing about the prenatal diagnosis. So from the obstetrician's point of view, a few things that we really need to know when we are talking about and thinking about thalassemias are chromosome, that these are on chromosome 11 and 16. Alpha beta is what is an adult hemoglobin. Alpha gamma is HbF. And why I am insisting this is that because our panelist would be talking about HPLC report. So alpha gamma is HbF. Delta is active after birth, epsilon is fetal life, and zeta is also seen in fetal life. So these variations in hemoglobin are some of the variation in these chains that are resulting in the problems. And Dr. Arora did mention that beta thalassemia, the switch of the hemoglobin happens after birth, and beta becomes the major part, alpha remains throughout, and the gamma comes down after birth. So HbF comes down after birth, and delta remains the same, which is accounting for the HbA2. So this is some basic hemoglobin switch based on which we are diagnosing all our hemoglobinopathies and problems. So when we talk about hemoglobin A or the adult hemoglobin, we have HbA alpha beta 96%, HbA2, which is the other common variant, up to 2.5%. Until the time that it is up to 2.5%, we are happy. and the HbF should be less than 1%. So this is our adult HbLC that we are talking about, the adult hemoglobin concentration in the blood. So now we will start with, recapitulating, I would say, but yet re-emphasizing that is there a need for routine screening for thalassemia? Dr. Vatsala ma'am, she's professor at AIIMS, and we are doing a lot of prenatal diagnosis for thalassemia. So ma'am, is there a need for routine screening for thalassemia?
Good afternoon, everyone. Thank you, Aparna. So if you look at the magnitude of the problem, we have a carrier rate which is 3 to 4% on an average in the general population, but in certain areas, it may be as high as 17%. And if you look at these numbers and the number of deliveries which are occurring, we have around 10 to 15,000 babies born with thalassemia major every year who would require blood transfusion. They have all the morbidities which has been discussed, like requiring chelation, etc. So of course, this disease has a significant magnitude of problem in the country. And again, there are other hemoglobinopathies also, which are structural defects, sickle cell disease, hemoglobin E, and others, which are again quite prevalent in certain parts of the country. And number two, do we have a screening test? Can we screen? Of course, we have screening tests, which are quite good. Even the simple screening tests like Nestrov and all have a high negative predictive value. And if you're screening, then we need to know if there is any intervention. And then of course, prenatal diagnosis is also available. So considering the magnitude of the problem, the availability of screening tests, and that we have a facility, we can do prenatal diagnosis. Of course, we should be screening for thalassemia for all pregnant women.
Thank you, ma'am. I think very nicely said. And all of these criteria that ma'am has mentioned is actually called the WHO criteria for the screening, whether we should screen for any disease. The disease has a significant magnitude. There is a screening test and there is a possible intervention after we have diagnosed screening. So this makes thalassemia an ideal condition to be screened in pregnancy. And yes, we should take this opportunity to understand and implement that in our daily lives. So now we come to the next question, Dr. Meenakshi. When should we suspect hemoglobinopathy? So on one side, yes, we are agreeing to the fact that we should screen for everybody, but there would be certain conditions, like Dr. Arora is such a strong proponent of doing HPLC for everybody. But when we talk about in the government setup or in general, when should we actually suspect hemoglobinopathies more than the others?
Very rightly said, Dr. Aparna. Hemoglobinopathies tend to be the commonest genetic abnormality which is seen. And unfortunately, or something, we come in the endemic belt as it is. So we know that in North India, thalassemias are most common, and in the Deccan Plateau, sickle cell anemias are highly endemic. So like you said, that actually we should be screening every patient, especially every woman when she's going to get pregnant. However, any woman who comes with anemia, with the family history, or doing tests like seeing that she's microcytic hypochromic anemia, and you've ruled out iron deficiency, she has a chronic hemolytic anemia, you see that she's had a lot of clotting in her body because there could be a vascular obliteration crisis, or a drug-induced anemia, erythrocytosis, hydrox fetalis in the past pregnancy, or like I said, if there's a family history, or as a part of prenatal diagnosis, we should be suspecting hemoglobinopathies.
Right. Thank you, ma'am. Some of the points, yes, become very, very important because, sometimes you might have missed, a routine screening, and still we should go ahead and not lose out on these opportunities. So now I'd like to know from Dr. Swati, what are the methods for screening? So what is this HPLC that we keep talking about? How do we screen for thalassemia? It's very easy to say HPLC, but a little bit more on the methods for screening and diagnosis of thalassemia.
Yeah, thank you, first of all, Dr. Aparna and Dr. Jyoti, for making me a part. Well, when we talk about screening, it can be a mass screening, which because that is applicable to low resource setting, like as Dr. Vatsala just said, a simple Nestrov test where you just need saline and buffered saline solution and distilled water, and you can just put in a drop of water and look it against a text, to see whether there is lysis of the red cells occurring or not, because it's said that the thalassemic cells are more resistant to lysis. So in buffered saline, saline, there won't be any lysis. So that is a simple bedside test that can be used in the community, as well as screening for just a hemoglobin in the community would give an idea of anemia, which can then further be subjected to screening. And of course, when you come to a district hospital or a beta center, then a complete blood count should be done for screening. At least a complete blood count with red cell indices should be done for screening for every woman, because HPLC, as we know in our government setup, is not possible. And those who are having microcytic hyperchromic anemia with an MCV of less than 80, with a MCH of less than 27, with peripheral smear showing target cells or basophilic stippling, they can be subjected to more diagnostic tests like high performance liquid chromatography, where we actually separate the various kinds of hemoglobin present in the blood, and which can tell us, if the HbA2 is more than 3.5%, it is kind of diagnostic of fetal thalassemia trait.
Right. So thank you, Dr. Swati. And I think you've raised out both the points on a mass screening and, of course, a more diagnostic test. So essentially what we have learned in our basic sciences is when we put an electrolyte solution and apply electricity to it, the proteins would move on the plate at different rates and velocity. And this is what we are looking at when we are doing HPLC. And what we see here is that the HbA2 is a band which stays very early, while HbF moves faster and the A will move even faster. And the abnormal hemoglobins like C, S, and BARTs are also detected. So this is a very simple method by which you can detect it. There are, of course, the other DNA-based methods which are done to actually genotype the type of thalassemias or type of hemoglobins, and also it is helpful in prenatal diagnosis. So essentially, it is DNA-based tests are not used as a first-line diagnosis. It is as a second tier, especially for confirming the clinically significant diseases in patients with suspected thalassemia, especially in the setting of prenatal and newborn screening. So now we will discuss some of the scenarios that we normally come across. So a primary gravida at 9 weeks of pregnancy presented with the following CBC report. So if you see the CBC here, there are certain findings that would, the RBC count is 4.18, the hemoglobin is 7. So why I have put this picture here is that we need to understand the CBC that we see in our daily lives. So hemoglobin is 7 gram%, MCV is 58. So when we, and predominantly microcytic and hypochromic RBCs is the finding in the peripheral smear. So hemoglobin is 7, MCV is 58, MC and RBC count is 4.18. So I would like to know from Dr. Angela that can we screen thalassemia from a simple CBC report? So what is feasible in low resource settings? So again and again, we are saying ideal is yes, you do HPLC for everybody, but we should also know how to interpret the CBC reports to look for thalassemia. So Dr. Angela?
Yeah, so that's one very important thing, that one should do a complete blood count, okay, for every patient, not only the hemoglobin. So a simple thing says if your MCV is less than 80 and MCH is less than 27, that shows that there is a thalassemia along with whatever anemia you have. Then you go for index, MCV over RBC. If it's less than 13, this goes for thalassemia. And otherwise it's for, if it's more than that, then it's an iron deficiency anemia. So these two very important parameters, what one has to look into it in diagnosing a case of thalassemia. And once you suspect that, then you can go for hemoglobin electrophoresis. But in a private sector, we get a report in 2 days time, but in a government sector, it takes a very long time. That's why the reason is do it preconceptional or do it at the first visit whenever a patient comes to you.
Yeah, so very important points that you have raised is the Mensa Index, where the ratio of MCV by RBC count. So if the RBC count is increasing as it would in thalassemia, the ratio is going to be low. Yeah. So this is how what happens in thalassemia is that it becomes less than 13. So what happened in this case is that when we calculated the Mensa Index, what you see here is 13. So the Mensa Index in this patient was 13. So now we have divided this 58 by 4.18 and we thought that it was 13. So there must be a problem. So this patient was advised HPLC. So in the HPLC, the HbF has come to be 0.9. And the other ones are HbA2 is 4.2, HbA is 93. So I would like to ask Dr. Poonam, how would you also interpret? So we have been discussing till now. So now this is like a real case that we are looking at it. So you have a HPLC report. How would you interpret it? So this is something like this, that the HbA has been given to a certain extent, HbA2 is given to a certain extent, and then you have HbF values. So ma'am, how would you go about it?
Thank you, Dr. Aparna, and thanks to Dr. Jyoti also. This particular report shows that the hemoglobin A, which is adult hemoglobin, that is 93.3%, it is quite normal. And HbA2 levels are high, 4.2. They should be less than 3.5. And her fetal hemoglobin is 0.9, which is also normal. So this particular patient is having beta thal minor, I would say. If the hemoglobin F would have been more than 50%, then she could have been in the category of beta thal minor. So this is a patient of, major. This is a patient of beta thalassemia minor.
Yes, so thank you, ma'am. Very nicely you have brought out. So the HbA2 is raised, HbF is normal. So when you have a trait or a minor, the HbF remains normal. While if you had a major, then of course the HbF will increase because you have absolutely got no beta chains. So yes, so this is a case of thalassemia trait and this particular patient, and this is how it is seen, that when it is beta thalassemia trait, the HbA2 lines becomes more darker and the HbF remains the same. But in major, the HbF will increase and this A2 is also increased to a lesser extent.
Yes.
So this is how we interpret HPLC. And when we actually now see the report next time, maybe we can look into it and really see what is happening here again.
So it's important we have to see the adult and fetal hemoglobin also, not alone the HbA2.
Yes, exactly. So now you see HbA2 here is 5.1. So again, so this is again in the range of a trait. So we look at the HbF here, but this is 0%. So then again, this is a trait. So this is how we interpret the HbA2 and we can decide. So if you have a 3.9 to 9 variety, then you have beta thalassemia trait, depending on the HbA2. But lesser than that, but more than 3.5, you might have beta thalassemia trait with iron deficiency anemia. And hence it is important to look at the other hemoglobins also when you want to look at beta thalassemia to diagnose the beta thalassemia. So between 3.9 to 9, you have a beta thalassemia trait with an HbA2 finding of that. So this was the first situation. Now I would like to talk about, so this patient was turned out to be thalassemia trait. Now, in this particular scenario, you have a fourth gravida para 3 live one with both parents having beta thalassemia trait. The first pregnancy, baby had jaundice, died at 1 month. The second baby again was diagnosed to beta thalassemia major, transfusion dependent. And third pregnancy, baby developed jaundice, later diagnosed. So in the fourth pregnancy, she came to us and both these parents were supposed to have beta thalassemia trait. Now, ma'am, as in the previous speakers have also spoken, but we would like to know again, like re-emphasize from you, how would you proceed for prenatal diagnosis?
So as both the couple are carrier of beta thalassemia trait, so they have a 25% chance of having a baby with thalassemia major, as it is an autosomal recessive inherited disorder. So to look for, so we can do prenatal diagnosis by using fetal tissue sampling. We can take chorionic villus sampling or amniotic fluid. So we have to look for certain common mutations, which we can sort of initially work up in the couple or the affected child. So if you're able to identify these common mutations, we can test them in the fecal sample, either as chorionic villus tissue or in the amniotic fluid. Suppose we don't have a diagnosis, we're not able to find these common mutations in the couple. See, there are almost like 80 to 90 mutations which can be there in thalassemia, beta thalassemia. But most of them, 80 to 85%, are because of the 6-7 common mutations. If we can't find them, we can move on to an extended panel and include some 8-9 more common mutations. If still you're not able to find any mutations, we can even do a whole gene sequencing to look for the mutations. So it's not that if you're not able to find the mutations, we're not able to do prenatal diagnosis by doing CVS and amniotic fluid sampling, that we have to go for cord blood sampling. We can still do sequencing. So as these couple have been worked up and we find that they have known mutations, so the next step would be, so when they are in the pregnancy, when the patient is around maybe 11 to 12 weeks, we can offer chorionic villus sampling And that is a good sample because you can get a lot of DNA, and then the fetal sample can be tested for the same variants as in the parents to see if the fetus is affected or not. So CVS gives you an earlier diagnosis. If your facility is not available or you're not dexterous in doing CVS, you can even go and do amniocentesis, but that would be a little later.
Right.
Thank you.
So thank you, ma'am. So like you have said, you have mentioned both the steps together, that yes, first the mutation was identified in this patient. So both mother and father were had identified mutation, and then a CVS was done for them. And in the CVS, we see that both the mutant alleles are detected in the baby. So this is a baby who has been affected with beta thalassemia. So this is detected and this is detected. So this becomes a major, and this lady chose to undergo a termination of pregnancy. But in another case of the patient where both the parent had trait, so one was detected and one was not detected. So in that situation, this is a beta thalassemia minor, and this baby is usually asymptomatic or having a trait in the adult life. So this pregnancy can be continued. So this is what we need to see and understand when we are going for a prenatal diagnosis, that once we do a CVS, if both the mutant alleles are detected, you terminate. If one is detected or 0 is detected, then you continue the pregnancy. So screening of the spouse, genetic counseling, mandatory screening, and then CVS or chorion villus sampling. If the normal fetus is normal, continue the pregnancy. Fetus is carrier. This is a bit of a controversy because carriers can continue pregnancy, or of course the option remains, but generally fetal carriers would continue pregnancy. And if the baby has both the alleles, then we choose to terminate. With that, we'll come to the next scenario where a third gravida previous to abortion mother is having a sickle cell trait, and the father with beta thalassemia trait. They had 2 previous unexplained losses. So what is the significance, Dr. Meenakshi, of sickle cell trait in the mother and its implications on prenatal diagnosis? So I'm sure in our practice, we do get a variety of combination of hemoglobins, which actually add to a lot of confusion. So sickle cell trait with the father having beta thalassemia. So what are the implications?
See, beta thalassemia being a quantitative disorder of the amount of hemoglobin which is there, sickle cell trait actually signifies a qualitative type of hemoglobinopathy. Now, in these cases, like both of them we assume are autosomal recessive, there is a 25% chance that the fetus will be absolutely normal, 25% chance that, it's a beta thalassemic trait, 25% chance that it's a sickle cell anemia trait. But the problem is that when there is the gene from both the places, that is that there is a sickle cell trait as well as the beta thalassemic trait, that all because they're autosomal recessive and there is no normal gene to kind of counter it, the sickle cell thalassemic trait becomes, a big problem, and that pregnancy will need to be terminated.
Yes, exactly. So as we know, there are quantitative and qualitative defects, and I've taken this up because, of course, it's not always pure thalassemia that we find. We find it combination with other quantitative disorders, and sickling, if it is combined with beta thalassemia trait, can have problems. So because both of them are autosomal recessive, but if they come together, then the baby can get affected. So the basic difference between sickle cell and beta thalassemia, of course, is that it's a quantitative defect. There's a single 1-point mutation. So the prenatal diagnosis is relatively simple. In thalassemia, you need multi-step diagnosis, as has been already discussed. So in this particular situation, the fetus was suggestive of sickle beta thalassemia, and the patient chose to undergo MTP in this particular situation. So this is one of the common scenarios we do come across where you have a combination of hemoglobins happening. Now in the scenario 4, we have a mother. We need to look here very carefully. A second gravida para 1 live 0 mother who had an IUD at 8 months pregnancy in the last pregnancy and by a cesarean and complicated by breech with antepartum hemorrhage. Now this lady has heterozygous hemoglobin E with beta thalassemia, but the father has a normal HPLC report. So this is something that we need to think about. So my question is, what would be the next step in management, Dr. Swati, and are all scenarios clinically significant for prenatal diagnosis? So this is a point which was briefly raised by Dr. Arora also, that not all hemoglobinopathies would need prenatal diagnosis. So Dr. Swati, would you like to talk about it?
Yeah, basically here, because the father's HPLC is normal, then if there is no chance of a child being born of a major hemoglobinopathy, at the most the child will be a carrier. So here there is no need for a prenatal diagnosis, but yes, there are other management issues that we need to consider in this patient, because considering that she is HBE beta thalassemia, then the spectrum of the disease may vary in these patients, ranging from very mild anemia to a severe disease. So we need to take a detailed history as to whether she has had, how anemic has she been, what are the drugs that she's taking. She may be suffering from iron overload, and which may give rise to conditions like diabetes and hypothyroidism in this condition, which might have been responsible for the intrauterine death in this patient. So that is important, that a complete evaluation of this patient is being done to actually know, the various drugs that she's taking and the associated endocrine abnormalities, any cardiac iron overload that she has had, and a detailed iron studies also need to be done in this patient.
Right, thank you. And also I would like to add a point here, that as Dr. Arora mentioned, that not all hemoglobinopathies need prenatal testing. So like if you're homozygous for HBE, HBD, then in that situation, you might not require a prenatal testing. It is only when you have a pathological kind of a hemoglobin coming with a milder form together. So in that situation only, it is like what happened with sickle and beta. So that is something that you would like to go for a prenatal diagnosis. But if it is a homozygous E in both parents, then you don't need a prenatal diagnosis. So this can get complex when we are trying to, really understand it. So I would really recommend that, we should take the advice of our hematologist colleague and fetal medicine specialist to sort out whether this patient really needs a prenatal diagnosis. So here I end the prenatal part and the fetal medicine part, and I would now like to invite Dr. Jyoti to talk about the management during pregnancy.
Thank you so much, Aparna. So now it comes on to all the obstetricians. After all the confusion, we've gone there and we're going to take help from all the fetal medicine and the hematologists.
I like that two comments to this previous panel discussion.
Yes, sir.
Comment. Okay. See, there is one case studied where the HbF was 0.9%. That is good. But at times, what you see, the HbF is say more than 1. That is say 5, 10 or 15 something. Not very high. 50, 80, 100, not 100. Say at the age of after 1 year, or when a lady comes to at 20, 30 years or so, then the fetal is around 5 or 8 or 10. Then it may be delta beta thalassemia. Then in that case, the HbA2 may be low. So if you on HPLC, if you see higher HbF, then ask for genetic mutations. Don't rely on HbA2 level only. This is one case. And another thing I want to say that there is one of fetus was carrier. To continue the, I forgot, sorry. There is another case for the regarding the fetus was carrier. Yes, that is say when the fetus is carrier, then it can be aborted. No, it is not. You cannot abort it. It is not legal. You then in that case, either you, if you are going for a abortion of the fetus of a carrier, then you are going illegal, and it is neither advisable morally, nor ethically, nor legally.
Yes, sir. When I wrote that, I thought that there would be a little bit of a controversy around it, but we do understand that definitely carrier is a person who's going to have a normal life. So definitely we would terminate only those pregnancies which are homozygous. Yes. Thank you for your comment, sir.
So now moving on to
sir, one more point, sir. Sir, yes. Dr. Arora, I would say that Dr. Deka has guided us and has taught us well in AIMS. So Dr. Vatsala and me, we are here for the thalassemia diagnosis.
I know, madam. I know. I have just put very big.
Yes.
Aparna, can I also make one comment?
Both of you.
Yes. Aparna, can I say something here?
Dr. Sangeeta, yes.
Yeah, whenever these patients of thalassemia carriers, they come to us, it is very important to initiate the cascade screening. They must be counseled that their siblings and their family members are very likely to be carriers, and the whole family should be screened. This should be a mandatory part of your counseling patients with thalassemia traits.
Yes, ma'am. Yes, definitely.
Yeah, thank you so much, Dr. Arora and Dr. Sangeeta.
Because somebody was saying that at times you are not, the patient cannot afford HPLC, or some at the government setup, the reports is very late. Very soon we are going to have our HPLC facility, maybe within a month or 2 months or so. Then we can provide this facility free of cost to anyone who cannot afford it.
Thank you so much, sir. And we're really looking forward to that particular facility for everyone. So moving on more to on the clinical aspect, that is about the pregnancy. So this is a 23-year-old primary gravida, married for the last 1 year, height 158, weight 61 kgs, who's been diagnosed with Thalassemia Major. And she presents to us at 6 weeks in the pregnancy. So coming to the question, this is Dr. Swati for you. What are the preconceptional concerns and measures you would like to be able to get the best pregnancy outcome at the very first antenatal visit?
Yeah, ma'am, she is a Thalassemia Major patient who has come to us for a preconceptional counseling. So as most of the points have already been covered by Dr. Arora, that, you know, we need to optimize the over iron burden of the patient. You know, it's very important that we assess her myocardial function, the myocardial overload, the hepatic iron load by doing echocardiography, ECG, and a cardiac MRI and a Ferry scan, so that, you know, an aggressive chelation therapy may be started. So because for the next 6 months or so, she will not be given any chelation therapy. Then we need to assess her diabetes, the hemoglobin, glycosylated hemoglobin levels, and more precise management is serum fructosylamine levels should be within normal limits. She should be euthyroid. And she should be switched on to, from oral chelating agents, she should be switched on to desferrioxamine, which is the only safe chelating agents in the preconception period, and also to be started on folic acid, 5 milligram per day in the preconceptional period. And if she's not been previously vaccinated for HBS antigen, then a vaccination also needs to be offered for this patient.
So Dr. Swati, this patient has already come to you at 6 weeks pregnancy. So at that particular time, yes, it's important to have a look at the medication she's already on at that particular time. So maybe these particular patients may be on chelators. We need to really stop those chelators at this time. So if for any reason they've been on biphosphonates, because these particular women do have osteoporosis, so that is another drug that we need to really stop. And as you rightly said, a 5 milligram of folic acid that we need to do on these. And very correctly, the two conditions, that's endocrinology, we have talked about thyroid, and the other one, we need to really look for the diabetic status of this. And fructosamine is a very valid point, which I think all obstetricians should know over here, that thalassemic patients, the way to monitor is by fructosamine. So what is the antenatal care that you would plan in this particular patient? That is, she's 6 weeks today. So how are you going to give her a roadmap as far as the planning of the antenatal care is concerned?
So we need to, besides the basic care, you know, get a 11 to 13 week scan, get a dual marker, and the routine antenatal care, she needs to be reviewed with us monthly till say 28 weeks, and then every 15 days. And we need to have a cardiology assessment at the baseline if a baseline cardiology assessment has not been done, and review it again at 28 weeks. And then accordingly, you know, if as and when the signs of cardiac decompensation occur. And also her thyroid status needs to be monitored. Frequent thyroid function tests need to be repeated, and also her blood sugar needs to be checked frequently at each visit. We should be checking that, you know, her blood sugars and her thyroid is well within control.
Yes,
definitely.
Dr. Jyoti, can I add here something?
Dr. Poonam, can you add here? Sorry, yes.
Yes. First of all, I want to just simplify the preconception care. We have to see 12 things in the preconception care that you can remember by 6 words: DISC, HB. DISC is like, D is for diabetes mellitus, and other D is for drugs. That is folic acid you have to add, and you have to change the chelators. I is for iron. You have to take care of iron. That is the how much to be your desferrioxamine, when it is to be given, and how much dose. And other I is for the infections. You have to see all the viral infections. She may be cytomegalo IgG positive earlier, but she may have secondary infection. She may have hepatitis. She may have many infections during pregnancy because of her anemic status. Then S is for screening. One is thyroid screen, and other S is for the genetic screen you have to do. C is for cardiac and your counseling part. That is, you have to counsel the risks of to the patient, and you have to counsel about the warning signs to the patient. Maybe her visit is due with you after a period of maybe 2 weeks or 3 weeks or maybe 1 month, but she has to be taught about the danger signs, or they have to be counseled at the first visit only. If she has palpitation, she has to rush to us. If she has any rash on the body, if she has any foul smelling vaginal discharge, if she has any UTI problem, then she has to come to us, whether her visit is due or visit is not due. So this is disc, then HB. H is for hepatic. That is, we have to see her liver condition and see how much iron is there in the liver and how the liver is functioning, because IHCP is also more in these particular patients, and viral infections of the liver is also there. And other H is for the general health of the patient, that you have to take care every time when she comes to you. Then B is for her bone health, because she may be having osteoporotic changes that Dr. Sangeeta explained in her PPT. And other B is for her blood, that is alloimmune antibodies which are there. So these 12 things you have to see preconception, and once you have to you have seen all these 12 things, then you have allowed her to be pregnant. And then if your patient is already under control, then her visits can be monthly till 28 weeks of gestation, after 28 weeks every 15 days, and always SOS, that you have already taught her, and she will come to you if she has any problem. And then your investigations, all routine investigations, Dr. Swati just mentioned, nothing to add in that. And then her cardiac status, which you had seen earlier, that has to be reviewed at 28 weeks of gestation again. And her diabetes status, we don't go like we go in our other patients at 24 weeks of gestation we do, and then at first visit. Here we do at first visit, then again at 16 weeks, then again at 24 weeks, and then monthly we will see her diabetic status. And whenever there is end organ damage is there, you suspect, and then you have to do MRI again, as Dr. Sangeeta told, you have to do MRI for content of iron in the liver, in the cardiac muscle, because that patient may go into cardiomyopathy if you don't take care. And coming on to the ultrasound, that is one routine scan to know intrauterine or ectopic and dating scan, then anti-scan as we do in all, and then level 2 scan you can do at 22 weeks and take care of her cardiac status also at that time. And then after 24 weeks, we have to do monthly to pick up the FGR in these particular patients.
Thank you so much, Dr. Poonam. I think you have put everything very well in a nutshell with all the synonyms.
We have patient who had splenectomy also.
Yeah.
So the
Yes.
vaccination before pregnancy is very important, whether it's hemophilia, typhus 2, meningococcal, pneumococcal.
Because the spleen size is sometimes that huge that uterus enlargement is hampered because of that.
That's right. So having screened a patient very well at 6 weeks, and we have actually milled and given her a written roadmap as to how she's going to move ahead, we now move to the very important part, that how should the transfusions be managed in these patients? And for that, I would like to invite Dr. Vatsala to give her opinion and the practice of transfusions.
Thank you, Dr. Jyoti. So for women who have transfusion-dependent thalassemia would require transfusion at regular intervals, and our aim is to maintain the hemoglobin at around 10 grams per deciliter. So naturally, they would require frequent monitoring of hemoglobin. Anytime it goes below, you have to give transfusions. Patients who are non-transfusion dependent, so that is one area where there is no guideline as to that you transfuse at this cutoff. So it'll depend on the hemoglobin level, as well as depends on the clinical condition of the mother, whether she's symptomatic because of anemia, like she's having fatigability, palpitations and all, then you would think of transfusing. And also if there is fetal growth restriction. And for these women also, if you plan to transfuse, then the target is the same. You have to bring up the hemoglobin to 10 gram per deciliter as for transfusion-dependent thalassemics. Other thing is, if these women have not required transfusion during pregnancy, but at the time of delivery, near term, say around 36 weeks, the hemoglobin is more than 8, you can transfuse afterwards. But if the hemoglobin is less than 8 and she is near term, like 36, 37 weeks, it's better to give her transfusion to bring up her hemoglobin to 10 gram per deciliter before delivery.
Yeah, thank you so much, Dr. Vatsala. But the only thing is that we should also always, because alloimmunity is a major problem with these particular patients.
So
we
for
need to be really careful.
non-transfusion dependent, yes. That's why we avoid transfusion and we don't go by a cutoff of hemoglobin. And the patients who are requiring multiple transfusion, again, there's a problem because they develop alloimmune antibodies. So cross-matching is important. So that also becomes a problem for them when you give repeated transfusions.
Yeah.
Thank you.
Yeah, thank you, Dr. Vatsala. So coming on to the next part, and we all know that these particular patients, because of this increased hemolysis, as well as that, they're very, very prone to develop thrombosis. So what is the antenatal thromboprophylaxis that is recommended? Dr. Vatsala, this is again for you. So should all patients be given here?
Yes, so women who have thalassemia, that are increased risk of thrombosis. So the guidelines say depends, like, so one condition maybe if there is a history of splenectomy or if the platelet count is more than 6 lakhs, then you can give you can give low dose aspirin in the antenatal period. If she's had splenectomy as well as there is high platelet count, then you may give low molecular weight heparin during the antenatal period. And again, in the postnatal period, you would like to give low molecular weight heparin to splenectomized patients at a higher risk of thrombosis. And the other thing is, yes, these women are also at high risk. So if you may give postpartum thromboprophylaxis to most of them, again, you may have to sort of individualize, but yes, at a higher risk.
Dr. Meenakshi, would you like to add something?
Is she there?
Is she there? Yes, Dr. Meenakshi.
Yeah, I think I agree. So I was just listening to Dr. Vatsala only.
So the point while I was reading, is the word the or and. So splenectomy or platelet, it's aspirin. Splenectomy and high platelet, it is both heparin as well as an aspirin. So we need to be really bothered about or and in this. But if they have not received any thromboprophylaxis before, whenever they are admitted to the hospital, because they're going to be immobile for a long period of time, that's the time we can consider giving them low molecular weight heparin. So, Dr. Vatsala, again for you, what is the optimal antenatal
management? Sorry,
management?
ma'am. Sorry, this is the antenatal management is Dr. Swati. Actually, I think it just got copied. So this is Dr. Swati.
Okay. So, Dr. Swati, we are coming back to you now. So what is the optimal antenatal management of iron chelation therapy? We've been talking a lot and not many of us know about this particular part. So could you just give it in a very practical aspect as far as these patients are concerned?
As a rule of the thumb, any kind of chelation therapy should be avoided during pregnancy, especially during the first 20 weeks. Oral chelating agents are a definite no-no. The only chelating agent that can be given during pregnancy is desferrioxamine, which has to be given by the subcutaneous route. Low dose of desferrioxamine is given around 20 milligram per kg per day, 4 to 5 days in a week. That is what is recommended. Now, when do we give chelating agents? This is a complex decision that the obstetrician alone cannot make. This is a decision that has to be made in combination with the hematologist as well as a cardiologist, because the main reason for starting chelating therapy in these patients is mainly a myocardial overload with impending cardiac decompensation. So if the routine assessment should be done at the beginning of the pregnancy by a cardiologist, and then at 20 weeks again an assessment should be done. But in between, if ever the patient presents with signs of cardiac decompensation, as in breathlessness, palpitations, paroxysmal nocturnal dyspnea, then in between also a cardiologist consultation may be taken. And if there is a feature of overload, then desferrioxamine can be started as early as 20 weeks of gestation. It can be safely given after 20 weeks of gestation. So that is what needs to be done.
Yeah, and another thing, that MRI is safe in pregnancy. We should not be scared because these patients need an MRI, and that can be done at 20 weeks. But the dose of desferrioxamine that we give is much less that we give it prior to pregnancy. That's only about 20 milligrams per kg that's given subcutaneously over the time. So considering the intrapartum care, now we have been very lucky and very fortunate to take her on to the full-term pregnancy, and now about the intrapartum part. So Dr. Poonam, what exactly are the considerations, the timing, the mode of delivery, and how exactly are we going to manage these patients?
Mainly our concern is that we have to do the fetal monitoring very rigorously, because these fetuses are already FGR fetuses and they are already chronically anoxic, and they may have fetal distress and other problems during the time of the labor. As such, I would say that thalassemia major is not an indication for LSES. And I think that's all. We have to give desferrioxamine, yes, 2 grams over 24 hours, that is to be administered during the labor. And we have to manage the 3rd stage of the labor actively.
So the main thing over here is that, first of all, when this patient comes, we should have a blood ready. And this particular blood should be cross-matched again, because we know that there can be a main chances of alloimmunity in these patients. And desferrioxamine, 2 grams. Here we are giving intravenously. Otherwise, desferrioxamine is given subcutaneously. Given intravenously, 2 grams over 24 hours, all throughout the duration of the labor. And yes, it's not an indication for cesarean. We need to take all the steps to prevent any PPH to take place. Now coming to the next.
And the continuous intrapartum fetal monitoring needs to be done.
Yes.
But these babies tend to be IUGR and they are with diabetes and all.
That's true. So coming to the next part, Dr. Intra, that's for you. That's the postpartum care. So now we have managed to deliver. How are we going to go about it postpartum?
Postpartum, we should continue with the chelating agents like desferrioxamine. But now after 24 hours of intravenous, we can switch over to the subcutaneous one, and definitely this secreted through the milk, but it doesn't get absorbed orally. So breastfeeding one is not contraindicated. The second most important thing is the thromboprophylaxis. Thromboprophylaxis should continue after the delivery for a minimum of 7 days after the discharge, and for 6 weeks after a cesarean section. And the most important thing which one should not forget is the contraception. Patient should be talked about the contraception, and she should not have any unplanned pregnancy for the future. If you look for the contraception barrier, progestogens, whether they are injectables, orals, or combined oral contraceptive pills later on, none is contraindicated in Thal major. So we can use any of these modalities in a patient with thalassemia.
Very well said. That means none of the contraceptive methods are contraindicated. All can be used depending on the choice of the patient. That can be done. So having moved on to there, we have been talking a lot about, will these patients ever get pregnant? We always have wondered. So this is a very small case about an infertility, just to highlight. She's a 22-year-old lady who's been married for the last 2 years and has come to us for the treatment of infertility. She was having irregular periods since menarche, but for the last 1 year, she's not having any periods. She's anemic, she's diabetic, she's hypothyroid. She's recently shifted to Delhi and has now been started onto the chelators. She's been otherwise a blood transfusion dependent. So if you have a look at the examination of hers, Dr. Aparna, can we have the next slide here? So she's 4 feet 10 inches, BMI is normal. She has got normal sexual characters, but when we did a PV, the uterus was a small size. Even on the ultrasound, it was just about 3 centimeters, and the total AFC count was 5. We ordered a hormonal profile where we found that the TSH was 8. She was on treatment, but we got a TSH. FSH and LH was less than 1. Estradiol was 20. But the AMH was fine. That was about 2.7. Definitely, she was anemic. So if we are looking at this particular patient, what we really need to know is what exactly is the cause of infertility in such a patient. So Dr. Meenakshi, this is for you, that how does thalassemia actually cause infertility?
So very clearly from the patient profile where you posted the FSH, LH, which are both very low, the patient is a case of hypogonadotropic hypogonadism.
Yeah.
So that is probably the most common cause and most common reason why infertility would happen in thalassemic women. Yeah. The pituitary, actually, there are these microinfarcts which will occur because of the iron collection there. Mm-hmm. And that is why probably the functioning becomes bad and the iron overload in the pituitary gland would cause this. Yes. So that is why it's very important that from a young age itself, we start these chelations so that the damage to the pituitary doesn't occur. Yes. It has been seen that these women also have a premature aging compared to women who don't have thalassemia at the same age. And in this case, like very clearly highlighted, there is the issue of hypothyroidism as well as diabetes, which could be adding to the infertility in this case.
Yes. So very well
just
highlighted.
Early detection, early management, and just when the girl is very young, not only to see that the thalassemia is managed at that time, but to please remember at that point that as a woman, her fertility is something which she would like to preserve at a later age. We need to start working towards in that direction also right from the beginning.
Very correctly said, Dr. Meenakshi. So we have already dealt with this before. That is exactly how you would like to evaluate before you actually go ahead for becoming pregnant. So Dr. Swati, the main points exactly as the headings that you would really like to evaluate this patient.
So basically, she is a case of hypogonadotropic hypogonadism, but that doesn't mean that other causes of infertility cannot coexist in this patient. Having said that, the first thing that before I start treating her for infertility, I need to first evaluate the partner as well, whether the husband is a carrier. Because if the husband is carrier, I can straight away offer her an IVF and pre-implantation genetic diagnosis if they want to, because anyways they're having trouble conceiving. So, and if the partner is normal, then I need to evaluate whether her sugars are controlled, I need to optimize her thyroid status, and also I would like to start her on chelating agents if she's not already on chelating agents to reduce the iron burden, because that will also help in a way in helping her conceive. But start on chelating agents like desferrioxamine, with which she will be able to conceive. And again, the evaluation by a cardiologist and endocrinologist to know the status of our heart, the status of our lung, vaccination, hepatitis B vaccination to be given if she's not already vaccinated, and folic acid supplementation, of course.
So that's true. I think we've already discussed all this in the pre-planning council, but only thing when we counsel this patient, it's important that it's a multidisciplinary approach where we have a cardiologist, a diabetologist, a hematologist. We need to optimize the patient before an ART. Don't jump to ART. We're going to have a lot of problems with the pregnancy there. We need also to explain to her the risks of ovulation induction, which are OSS and the multiple pregnancy. All other options have to be discussed. We just are not talking of an IVF or an IUI. We need to tell them there's PGD, there is surrogacy, there's an option of adoption. And at this time, tell her that if she wishes to become pregnant, this is going to be a high-risk pregnancy and she needs to deal and understand the consequences of a high-risk pregnancy. So moving on to the next, and that's Dr. Poonam to you. For this particular patient, what is the protocol that you would like to take for her? She's a hypogonadotrophic hypogonadism.
In this particular patient, you had told that uterus size is 3 centimeter, and that is also, size is very small, or pre-pubertal size of the uterus is there. So in this particular patient, when I am preparing her and when I am correcting her diabetes, I am correcting her thyroid. Meanwhile, I can put her on OCPs so that she may have regular periods and the uterus size may become little better. And after that, just a minute. Sorry. Then after that, we will have to use the HMG for this particular patient. Then HMG, and I think in this particular patient, we can use 225 HMG because we don't want her to be hyper stimulated also, and can go for IUI if her tubal status is okay, because her husband's report you had put it to be normal normospermia. And in case if she doesn't conceive with the IUI 2-3 cycles, or there is a problem in tubal status, then we will move to ART, that also with the same HMG, and then trigger with the HCG we can give in this particular patient.
So we need to understand that with HMG, we have a very good ovulation induction rate up to the tune of 80%, and we can make these patients pregnant by using HMG. We just need to tell them, nahi, kuch nahi ho sakta tumhara. That is not the attitude we need to have. So coming to
spontaneous pregnancy also, this patient can achieve when you put her on that. You may even don't need IUI because her male partner is normal.
Yes. So coming to the last question, that's Dr. Angela for you, that what are the options, when I said that we need to give her the whole array of options that are there, what are the other options that we can offer to her? So Dr. Angela, are you there?
Dr. Josa, is she fit for pregnancy? 6 gram hemoglobin, diabetes, thyroid? It is not that, because just for discussion, we are discussing it. Is she fit for going ahead with these kind of things?
Ma'am, when we are making her fit, in the meantime, for 6 months or so, 4 months or so, we can put her on OCPs to make her uterus. But before doing anything at all, we have to counsel her a lot more, that whether she should even decide to go for this or not. And if she is adamant she has to go for that, then these are the options we have.
Nobody's adamant if you find the counselors are good.
So, ma'am, that's why we've come to the last. And that is what are the options should we have given her? Not just ART, we have many other options for her. So, Dr. Intra, this is for you.
Yeah, you know, the one thing is she can go for a egg donation or a sperm donation, but after screening for hemoglobinopathies. Sperm donation is better because it's effective as well as not invasive, and one can go for an IUI or ART after that. Second most important thing is if this woman wants to adopt, you know, or go for a surrogacy, that's also not a bad idea because she herself is a very high risk patient for that, you know. Adoption is one when her own thing is end organ damage is there, or is a failure of ART, or she doesn't want to go through all invasive kind of procedures and just want to go through that, then she can adopt the baby. Surrogacy with your own egg, or whether the sperm donor or the vice versa, they can choose it, you know. So, you know, whenever you are counseling a patient, you know, for any kind of infertility where both partners are Thal minor, then it's, or patient is Thal major, it's very important you sit down, make a tree for her and explain to her what is her problem and how she needs a PGT, expense related to it, and then other options and their cost, so that she makes a good choice, which is suitable for her, for her health also, because as Dr. Sharda Jain ma'am said, it's a high-risk pregnancy. It's very important that she must understand it's a high-risk pregnancy. It's very easily written that she has a follow-up every 4 weeks till 28 weeks. Now you tell me from first visit till 12 weeks, she will have so many follow-ups, you know, and there's so much of trauma going on. So it's very important that she should be in touch with the mental health team also to help her out from the emotional trauma also, which honestly we have forgotten in her antenatal and intrapartum care, you know.
Yes, I think the multidisciplinary should also include
A psychologist
also in that particular one, apart from just the clinical aspect of that particular one.
So with this, just a minute, I have one clarification for my this knowledge, that you said any contraception can be given. But I think if they are having splenectomy or in thalassemia intermedia, I think the estrogen-based contraception may be avoided because of thromboembolic events. What do you think?
You are absolutely right. Basically, nothing is contraindicated. The way we evaluate for every patient, look, if this patient has some kind of a thrombosis or something, anyway, there is going to be no. But it's a very important point which you have said. If there's a splenectomy or previous thromboembolic disorder in this patient, then one should avoid it. Otherwise, none is contraindicated in this patient. And it is also written in very clearly in all the guidelines.
Sir, and I think Dr. Angela also said hormones, because, you know, this was a postpartum situation in which anyways we are not giving estrogens. Normally in the postpartum situation, we only give either POPs or, you know, a postpartum IUCD. So estrogen is avoided in the entire postpartum period anyway. So I think that is something that we also need to keep in mind.
I was asking for contraception because at one point of time, somebody said in contraception, you can give anything.
Yes,
so,
sir. Contraception so also in context of the postpartum contraception.
Okay.
Yeah.
Thank you.
So with that, we come to the end of a great interactive session. And I would really like to thank all the panelists for the great inputs. I think we've been able to make a lot of things very clear today for all the obstetricians, very simple things that we can implement into our practice. Hemoglobinopathies are basically divided into disorders of globin, that is thalassemia, and the structural variants. It is considered an important differential for microcytic hyperchromic anemia, especially in certain geographical areas. We always should have a high index of suspicion along with the algorithmic approach for the diagnosis, and that is very prudent. Prenatal diagnosis forms an important aspect for diagnosis and thus preventing a baby being born with thalassemia major. The survival rate of thalassemia major patients is increasing, and with more women reaching reproductive age group, they will definitely wish to have children. That is where we have a role of infertility specialists. They will get pregnant, and that is where the preconceptional counseling, optimizing them before they tend to become pregnant, that is where very important. And of course, always the hemoglobinopathies in the male partner should also be investigated at the earliest to be able to rule that out. So with that, I think we come to the end of this particular session and the webinar. And if there are any questions, then we have a very less time. We just have we can take 2 or 3 questions, Dr. Neha and Dr. Seema, if they're in the box and not answered as yet.
Ma'am, all the questions have been answered. If somebody would like to question anything.
Yeah, I like to ask something. You know, I have read in the literature a patient who, can you hear me?
Yeah, we can. Yes.
A patient who have undergone splenectomy should get penicillin prophylaxis during pregnancy. So which penicillin and which dose? Honestly, I'm not aware of it. So I thought I will ask from experts, you know.
So Dr. Deepika and would you please?
Benzathine penicillin 2.4, same as we do in cardiac patients.
I can't comment on during pregnancy, but otherwise we give Pentin 400 or 200 depending on the age and the weight of the patient. That should be given. If they are allergic to penicillin, then we give erythromycin or amoxicillin. But I cannot during pregnancy.
Okay.
That's safe in pregnancy, so we should be able to.
Yeah, erythromycin. Yep.
That's what that particular one is there. So. So with that, I invite Dr. Aparna to give a vote of thanks. And Madam, Dr. Jain, ma'am, any comments from your side, ma'am? Ma'am, you're muted. Ma'am, you're muted.
I think it was a great session. Everybody of us learned quite many things. And I think this we must keep this momentum of pressurizing gynecologists that they should be screening, and not allow any major thalassemia major child to be born, and which is doable at least in the city of Delhi. I am told that in city of Delhi itself, quite a bit number in 1,000 the thalassemic major children are born, which is very sad.
Absolutely, ma'am.
I'm only one particular about things, you know. We must assess the patient's situation. If the patient is sick, she's anemic 6 gram, she is diabetic, she's thyroid, how are you considering for infertility? वो अपनी जिंदगी चला ले वही बहुत है.
You are absolutely
realistic.
Yes. I want to ask one very important question. You know, we have a patient who husband wife both were thal minor, and she aborted once and then had myomectomy, again thal major, and then she became pregnant. We did all the mutation genes and gene sequencing, and then PGT was done, and then CVS. I wanted to know, once you do IVF, okay, and you have done pre-genetic testing and you put those embryos, you know, in a woman, do you still need to do CVS or amniocentesis?
Yes, we do. This is the protocol.
This is a protocol.
Yeah. But why? I have no idea. I know it was done on that patient, and that she delivered a beautiful girl 2 years ago, and Dr. Pai has reported that, you know. But this is from my knowledge. Why you want to do that once you have already done, and there is always a miscarriage rate? You know, this is just a knowledge for all the obstetricians.
Dr. Angela, human error is always there. You can never take it.
Okay.
But madam, when PGD is done, then why it is required? Even I'm not aware of why it should be done.
Sir, this is protocol we always do.
No. This is a protocol set up by, that's what I wanted to know. I'm not saying somebody has done this like this. I wanted to know as a general obstetrician knowledge.
Angela, I think because in PGD, you are only testing one single cell. And the scope of error is significant. You know?
Okay.
So maybe I'm not sure, but this is my logic behind it. You're just taking one cell.
As such, PGD is not very popular because of these reasons, because they can be never 100% surety.
And also you're testing the trophoectoderm which may not always be similar to to the inner cell mass which will develop in the embryo. So there may be a difference between the two also. So that may be another reason that you have to, any PGD you do, you have to confirm.
And secondly, PGDs are usually, considered only screening tests.
Okay.
They are never considered to be diagnostic tests.
So it's very important that we counsel a lady from the very beginning that you have to go for a CVS. Will you do CVS then or wait for an amniocentesis?
I think that
CVS
choice
is now
the
as
couple
good
will also.
as amnio, ma'am. CVS is actually better because it's been seen that most of the loss rates are similar, so no problem.
Great, thank you.
For an early diagnosis, so even if termination of
CVS में
pregnancy
cell mass,
required,
you get the number of cells are more in CVS.
you get is it's like more than what you get with amnio, but I think it can be done equally well in both the samples.
Yes,
It depends on the lab.
Yes.
That depends on the.
Dr.
But
Achal,
the thing is,
Thank
ma'am,
you.
you have to wait for amnio. You have to wait till 16 weeks.
Yes.
Here you
Yes,
are ready with your
absolutely.
diagnosis at 10.
You have to
10,
tell
11
the
weeks.
patient. You have to ask the couple. It is their
It's
choice.
very important
will,
that you talk to them, before even transferring their embryos, that this is the protocol we follow,
So Dr. Achal, anything from
Counseling
you?
is very, very important.
A couples opt for PGD only because they are having repeated Thalassemia Major patients to be aborted. They primarily go for PGD for this thing only. And then after that, you have to go for CVS. So, and some couples don't want to go for CVS. That is why they want to go for PGD.
So maybe near future, they will be able to do it through non-invasive prenatal testing.
Yes.
That may be the future then.
What is the status of maternal serum?
That's what I'm saying. It's like still an experimental thing, but that may be the future. We don't have that facility available, but it can be done.
Fine.
So I think that is an extremely healthy discussion and something new frontiers that we did chalk out over here. So Dr. Achal, anything from your side before we close?
Yeah, definitely. I was waiting to say that a very quality webinar by Quality Implementation Committee. And I think the quite a few things were covered. And like Dr. Jain said that though we are covering everything, but the patient has to be individualized. And you have to decide now which patient you will allow, counsel her that she should get pregnant and which patient should lead her life, healthily, which is more important for her. But I think very well done, Jyoti and Aparna.
Thank you very much. And I would now like to invite Dr. Aparna to give the vote of thanks to everyone who's here today.
Thank you, ma'am. And it's really my proud pleasure to deliver the vote of thanks. And I would really begin by acknowledging and also, we are very, very privileged to have Dr. Sharda Jain ma'am with us today for the whole webinar, and we've received her comments. So thank you very much, ma'am, for joining, for encouraging us always. And of course, we have with us the president of AOGD, Dr. Ashla Batra ma'am, who has been also there with us throughout this seminar. And ma'am, thank you so much. AOGD actually promotes all of the people so much that we are so inclined to keep doing academic programs. I would take this opportunity to thank all the speakers and the chairpersons of the sessions who have done a wonderful job. This is actually a very specific topic, but all of them have actually managed to make this such an interesting session. I would thank all the committee members of DGF and the AOGD QI committee who have helped us organize this webinar in such a flawless manner. Dr. Seema, Dr. Neha, and of course, Dr. Jyoti, who is not just very academic, but also very poetic. And of course, I would like to thank all the audience who have joined us today and listened to us throughout. And we really hope that this was helpful. And even if there are further comments and, queries, we are you're most welcome to, write to us. So with that, and I'd like to thank the platform here provided by AOGD, Conferences International, who as usual have done a marvelous job. So thank you very much to everyone and have a great evening. Thank you.
Thank you.
Special thanks to Dr. Dekha and Dr. Arora.
Thank you, madam. Thank you.
Thank you very much, everyone. Have a good evening. Bye-bye.
Bye-bye.